Okay, everyone, welcome back. We are continuing on with our thyroid pathology. So we are going to be talking a lot when we do these pathology lectures on benign versus malignant versus kind of physiologic processes. And when we're talking about specific tumors, we're talking about either a benign or a malignant tumor. When we're talking about some of these conditions, we're talking about the physiologic process of that condition. So that organ is no longer functioning the way that it should be, resulting in these processes that we're now going to be talking about. So our thyroid has a lot of those, and we're going to start with those in this lecture. But before we get into them, we are going to kind of recap what we finished our last PowerPoint off with in terms of how we measure certain findings when it comes to the thyroid. So we're measuring SAG, we're getting a SAG measurement, we're getting an AP measurement, and we're getting a transverse measurement. Now we're getting a length in sagittal, and we are getting an AP or a height, anterior, posterior, in transverse, and we're getting a width in transverse. So we color coordinated everything on these images for you. So when we're looking in sagittal and we have that elongated nodule or that elongated finding, we're doing the length measurement. When we turn transverse on that and we're now looking at it on a cross axis, when we're measuring anterior to posterior, remember anterior is always top of the screen, posterior is always bottom of the screen. That's going to be our height. And then our width is going to be side to side and transverse. Now, the same thing can be done when we are measuring the thyroid itself. Now, this is something that is going to be a little bit different from tech to tech or protocol at one place versus protocol at another place, but we are oftentimes going to still see our length and our AP height of the thyroid itself be done in sagittal and our width be done in transverse. So when we're measuring just the thyroid, we're doing 2 measurements in sag, 1 measurement in trans. When we're measuring a nodule or a finding, we're doing 1 measurement in sag, 2 measurements in trans. So very confusing, and we're starting you off with a confusing method. So welcome to this semester. So here we have a bunch of different findings. You can come back to this slide once we finish off this PowerPoint, see if you can kind of place any of these abnormalities here. But let's get started with those physiologic processes. So one of the most common things that we are going to hear about in terms of indications for an ultrasound exam is going to be hypothyroidism and hyperthyroidism. Now, hypo, right there in the word, it's saying that there's not enough of something. So we have hypothyroidism, the undersecretion of those thyroid hormones. We just learned about those in our previous PowerPoint. So this means that we can have low intake of iodine, we could have thyroid hormone failure, we could have something abnormal happening with our hypothalamus or our pituitary gland. So there are a lot of different causes of hypothyroidism, that undersecretion of those 3 main endocrine thyroid hormones. Clinically, we are going to see rapid weight loss in these patients. We could see constipation, hair loss, increased tissue around their eyes. They're going to be tired or lethargic. They're going to see a decrease in their motor and intellectual skills. They're going to be searching for words. They're going to be having a hard time concentrating. They are going to be very cold, and they could even develop a deeper, husky voice, some severe cases of hypothyroidism. So these hormones are really responsible for all of our metabolic processes, right? It's really all of our hormone levels are really going to be so driven by the thyroid, by the pituitary gland, by the hypothalamus. So on ultrasound, we could potentially see an enlarged thyroid. When we say an enlarged thyroid, this is termed a goiter. Now, goiters can occur for any different reason, right? We will talk about that as we get through the PowerPoint here. But when we're seeing the word goiter, we know that that means that our thyroid is larger than it should be for a variety of reasons. We also are going to see diffuse nodularity. So this means that the thyroid is going to be a lot more lobular, even internal lobulations. We're not going to see that nice homogeneous appearance. And then ultimately the main ultrasound appearance of hypothyroidism, these are mainly going to be chronic cases of this condition. Like the patient's had this for so long and it just keeps getting worse and worse and worse and worse before they get a diagnosis. Because of that long period of time of this undersecretion of these hormones, the thyroid is going to start to become atrophic and it's going to atrophy, which means it gets smaller and smaller and smaller and smaller until ultimately we don't even really see any thyroid tissue left. So a lot of times with these patients, they come in for exams, we put the transducer down, we don't see anything. And we're asking them, did you have your thyroid removed? You didn't have a thyroidectomy? Are you sure? Are you sure? And in reality, their thyroid is so underfunctional that it has started to atrophy and just decrease in size to the point where there's really nothing left to it. So we can see an enlarged thyroid in really early cases of hypothyroidism, but mainly we are going to be seeing this chronic, small, potentially even disappearing appearance of this thyroid. So if you look at this picture here, we see our trachea, we see our carotid, we see our jugular, and don't really see any thyroid tissue, right? It should be sitting right here. And we're not really seeing anything. So that's how small and atrophic this patient's thyroid has become, to the point where we're not even really seeing anything. Now, on the opposite end of the spectrum, we have hyperthyroidism. So now this is when our thyroid is secreting too many hormones. We have this over-secretion of those hormones. So again, this can be caused by any type of abnormal hormone imbalance, mainly could be caused by a localized mass, either a pituitary gland mass or a hypothalamus mass that is causing this overproduction of hormones. So if you think about it, if you have a mass in the pituitary gland or the hypothalamus, those are regulating structures, right? They are regulating and secreting these hormones that are then signaling and triggering the next structure to secrete the hormones. So if you have a mass on that structure that's responsible for this very delicate regulation, it's just going to think that it needs to constantly keep producing, right? It also can be caused by Graves' disease, which we will talk about in a second. On ultrasound, we could still see a homogeneous thyroid, but it's going to start to become more hypoechoic in its echogenicity. It also is going to become a little bit more enlarged, and we are going to see a little bit more prominent color evaluation. So when we put that color on this tissue, it's going to light up quite a bit more than just regular normal functioning thyroid tissue, right? It's overproducing, it's overacting, it's overfunctioning. So the vascularity to it is going to appear to be more as well. Clinically, the patients are going to have a severe increase in their metabolic rate, which is going to result in that rapid weight loss. On the previous slide, I apologize. I'm going to go back one second. I think I misspoke here. Yes, so this is going to hypothyroidism. Everything slows way down, right? That metabolic rate slows way down because we don't have those hormones driving that metabolism. So patients with hypothyroidism are going to have weight gain. I think I said they are going to have weight loss a few moments ago. So moving back to this one, so hyperthyroidism, our metabolism is way too fast. We're going to have rapid weight loss. We're going to be super hungry all the time because of it. We're going to be shaky. We're going to have tremors. We're going to be sweating because our metabolic rate is way faster. We are going to be hot all the time, again, because our metabolism is just going. That can cause heart palpitations as well. And then we could also have exophthalmos. So exophthalmos is when our eyes start to kind of bulge a little bit. If you've seen those commercials for like, I think it's like a thyroid eye disease, they call it on the commercial. There's like a medication out there for it, and it's basically a woman who just is constantly wearing sunglasses because she's embarrassed of her eyes that just seem to be protruding more than they were before because of this thyroid disease. So exophthalmos, that's going to be our medical term for that. If you think about it, opth, anytime we see the kind of prefix opth, that is talking about our eyes, and exo means outward, right? So exophthalmos. So if we look at our picture here, we have our slightly enlarged thyroid. It's a little bit more hypoechoic than we've seen on previous normal thyroid pictures. So moving into our Graves' disease, so this is going to be closely related to that hyperthyroidism, right? It's actually the most common cause of hyperthyroidism. It's also known as thyrotoxicosis or a thyroid crisis or storm. So basically what this is we have the body producing thyroid stimulating immunoglobulin, a little bit different than what we've been talking about up until this point. So basically we have this new hormone coming into play here, and it's being kind of produced higher than it should be. Therefore, the thyroid is having to compensate for that. So it's related to autoimmune disorders. So if you have any type of autoimmune disease or condition, this is something that you are probably being monitored for and tested for, because we don't want it to result in hyperthyroidism. It's also most common in women over 30. On ultrasound, we could see the thyroid still pretty homogeneous and also hypoechoic as well, just like that hyperthyroidism. But it's again going to start to become enlarged, and we're going to see that hypervascularity. So there really is no sonographic way to tell the difference between Graves' disease and hyperthyroidism, because they're both going to look the same. This differentiation is going to come from their blood work, from their other clinical symptoms. So although they're very closely related, we are going to be able to determine like what caused this condition. Like, does this patient have Graves' disease where it's, we have these abnormal levels of immunoglobulin, or do they have hyperthyroidism for, whatever other reason? Now, clinically, we are going to see goiter. So that is that enlarged thyroid. We could see abnormalities with the eyes as well. So again, that exophthalmos, also visual changes with our eyes when it comes to Graves' disease. You could see tachycardia, that increased heart rate, tremors, muscle weakness, weight loss, again, very similar to hyperthyroidism. Next, we have thyroiditis. So this is the infection of the thyroid tissue or caused by autoimmune abnormalities. So a lot of autoimmune diseases kind of mock infections and inflammation in the body. So basically, when you have an autoimmune disease, your body is being led to believe that there's something that you have to fight off, right? And you can't do it. Like, your body just can't complete that action. So the organ is going to respond in the same way as if it were fighting off an infection or some type of inflammation in that area. So thyroiditis is going to be caused by either that infection or autoimmune abnormality. So thyroiditis, when we're talking about an itis, we're talking about inflammation. So this tissue is going to become inflamed. It's going to be responding to either that autoimmune disease or that infection to try to fight it off and get back to normal. Clinically, the patient is going to feel that tenderness, just like when you have any other inflamed type of tissue. Think if you've ever had like an ingrown hair on your body somewhere, like that feels like tender and it swells, right? That's what's happening when you have inflamed tissue, when you have any type of itis. So thyroiditis, we're going to see that swelling, we're going to see that tenderness in terms of patient complaint. We also, if this inflammation goes on for a period of time without being treated, whatever the cause may be, whether it's caused by an infection or an autoimmune disorder, it's going to result in hypothyroidism. Anytime you have inflammation of any tissue, that tissue has slightly higher temperature levels, right? Again, think of that ingrown hair. It feels hot to the touch. right? Or if you've had any inflammation anywhere in your body, it feels hot to the touch. So anytime we have that increased temperature of an organ for a prolonged period of time, it's going to start to kill off all of the normal, healthy, functioning cells. And that's going to happen with the thyroid. So the thyroid, it's inflamed for so long, we're not treating it, not treating it, not treating it. Ultimately, that tissue is going to start to die off because it's been trying so hard for so long to fight whatever the cause of this inflammation is. The heat from this inflammation is causing damage to those tissues. So it's going to result in those long-term cases of hypothyroidism. Now on ultrasound, it still could appear homogeneous, but now this is where we're going to start to see some of that heterogeneity coming in, depending on how long we've had this inflammation. We're also going to see it enlarged, right? Because it's inflamed. This tissue is inflamed. It's going to appear nodular, so the tissue is going to start to appear a little bit more lumpy, bumpy. It's also going to be hypervascular. Anytime you have an inflamed area of tissue or an inflamed organ, our body is sending in blood supply to try to fight it off. So when we put color on, we're going to see that flow. Now, if we look at our pictures on the right, I keep dropping my microphone, I apologize. If we look at our pictures on the right side, we can see that this right lobe is starting to look a little bit bigger and a little bit more kind of asymmetric from the left lobe. We have this whole of abnormal tissue right here. So that's thyroiditis starting in right in that region. Now, if we look at the picture on the bottom, that's just showing us that hypervascularity, that increase in blood flow when we put our color on. Next, we have de Quervain's thyroiditis. So this is kind of like what we call a subacute thyroiditis. This is a type of viral inflammation disorder. So say you have some type of virus that you contract for whatever reason, it can ultimately spread and affect our thyroid. We could see the entire thyroid affected by this virus, or we could just see a portion of the thyroid affected. And of course, anytime it's inflamed, we are going to have that enlargement of the tissue. We're going to see it become hypoechoic. We could even see potentially decreased vascularity, which is a little bit abnormal for any type of itis, but we can. Usually we're going to see normal vascularity with this type of thyroiditis, and symptoms: fever, neck pain, fatigue, tenderness, dysphagia. So all of this is going to kind of make sense in terms of a viral contraction, right? Fever, fatigue, tenderness, that all kind of goes hand in hand with fighting off any type of virus. Next, we have Hashimoto's. So this is actually a form of thyroiditis. So it's still a type of inflammation of that thyroid tissue, and it's actually the most common form of thyroiditis. So we're seeing Hashimoto's more than we're seeing any type of viral thyroiditis or any type of autoimmune thyroiditis in terms of anything outside of Hashimoto's. So Hashimoto's, we are going to see this in younger or middle-aged women. It is itself considered an autoimmune disorder where we're having that chronic inflammation of the thyroid. Clinically, we are going to see enlargement or a goiter. We could see it either on both sides, like the whole thyroid, that would be our goiter, or we could have just a focal or an asymmetric region of enlargement. We are mainly going to see painless Hashimoto's or slightly mild tenderness of the neck. And chronically, it's going to result in hypothyroidism, of course, as we said with other forms of thyroiditis. On ultrasound, we are going to see a hypoechoic thyroid, variable in size depending on that enlargement, whether it be diffuse or asymmetric. We could see microlobulations, which kind of is a little bit worrisome. We never want to see microlobulations, but in the thyroid, if we're having all of this associated blood work to support Hashimoto's, we're not going to be concerned for thyroid malignancy or cancer. Acute on ultrasound, we're going to see increased vascularity, and chronic on ultrasound, we're going to fall into that hypothyroidism category. So now we're going to see decreased vascularity. So again, all depends on the severity and the duration per patient. And it's going to look just like every other type of thyroiditis. Now moving into every sonographer's worst nightmare. We have non-toxic multinodular goiter. A multinodular goiter, MNG, G is never an indication you ever want to see coming on a requisition for a thyroid exam. These exams are tedious when you are starting as a student. These exams will make you question yourself. These exams can be very discreet and challenging. And even as a tech of almost 10 years, I still do a little sad sigh every time I have to do a multinodular goiter thyroid. So what actually is this? What am I talking about? What am I complaining about? It's diffuse thyroid enlargement not caused by any type of malignancy or inflammation. So we have this overall enlarged thyroid, but why? There's no tumor per se. There's no malignancy that's making it enlarged, and there's no inflammation or infection that's making it enlarged. So why is it enlarged? Well, the gland is unable to provide an adequate supply of thyroid hormone. So because of this thyroid imbalance, we get these little abnormal nodules in the thyroid tissue. Now, clinically, we are going to be able to feel that goiter. It's going to feel like a very enlarged thyroid on the anterior neck, and they are going to have hypothyroidism, again, because we don't have the adequate supply of these thyroid hormones. On ultrasound, we can see a smooth thyroid, but we are usually going to see a nodular thyroid. We're going to see compression of the surrounding structures depending on how big this goiter is, and we are going to see it enlarged in a uniform sense. So this means that the right lobe and the left lobe are both going to be enlarged. It's not going to be one or the other or small regions enlarged. This whole thing is going to be enlarged. So here, when we look on the pictures to our right side, we have all these little arrows pointing to all of this craziness. This is now our isthmus. Look how big that is. That's wild. That's super, super thick. Now, I'm going to erase this. Now, depending on where you work and protocol and physician preference, they will make you measure in 2 planes, 3 measurements, all of these nodules. And remember, this is just one slice of the thyroid that we're getting. So absolutely crazy. These are really hard, especially when you're first starting out. And especially when, some of those nodules may have looked pretty obvious to you. Let me erase them so you can kind of go back and see. But you can probably see a lot of these circular masses, right? Pretty obvious. And then you get the ones that probably aren't so obvious, right? This guy. You may not have saw that if that arrow was there, right? And this guy right here, you're probably thinking, okay, it's that anechoic circle here. Nope. It's that whole thing with a cystic component. So thyroid nodules are going to be extremely, extremely challenging. We're going to continue to talk about them. So now let's move into our toxic multinodular goiter. So very similar to non-toxic multinodular goiter, this is going to be kind of the opposite of that. So it's going to be the hyperplasia of the gland, primarily associated with hyperthyroidism. So you have your abnormally high thyroid levels, and the tissue just keeps proliferating, and it keeps growing and growing and growing and growing, and it gets bigger and bigger and bigger. Now, this clinically, we're going to see abnormal serum levels. We're going to see an abnormally high thyroid stimulating hormone from the pituitary gland. And then we're usually going to see hyperthyroidism. But again, depending on how long this has been going on for, we could see hypothyroidism in chronic cases. On ultrasound, it's going to have a very similar appearance to the non-toxic multinodular goiter, and it's going to also have similar appearances to thyroiditis. So remember, hyperthyroidism, overacting, inflammation can lead to chronic hypothyroidism. So all of these physiologic processes are all kind of very closely related to each other. They all have some similarities in terms of ultrasound appearance, so we need to be aware of the patient's clinical history and any information that we can find in their chart to kind of help us piece these physiologic findings together. Now let's move into our benign pathology. So now we're going to be talking more so about specific findings or tumors or masses. So all of these are benign. None of these are cancerous. We're not worried about any of these for cancer. First is going to be our colloid cyst. Super common finding. They're kind of cute sometimes. I don't know. That probably makes me weird that I think that they're cute, but they kind of look like a little eye. I don't know. I like them when I see them while I'm scanning. So these are going to be benign, fluid-filled little sacs within the thyroid tissue. It's actually a dilation of those follicular cells on that very cellular level. So a little portion of that tissue just got dilated and allowed for that fluid to kind of sit there and become a little sac. They're typically going to be very small, but they can grow, and it's common to see that central echogenic foci in the middle. So we have that little hyperechoic punctate focus right in the central portion of that cyst. Next, we have nodules. So similar to the multinodular goiter, we can have one nodule, two nodules. We can't have nodules without it being any type of thyroiditis. So when we have this variable gland enlargement in a specific kind of focal region, that's when we get a nodule. Now, causes of nodules, thyroiditis can cause them. Any type of tumor development, benign or malignant, can cause them. Hashimoto's, nodular hyperplasia can cause it. So there's really kind of anything that can cause it and also nothing that can cause it. Like you can just randomly get these nodules and we don't particularly worry about them, especially if they fall into those normal TRADS grading categories. On ultrasound, these are going to vary from patient to patient. We could see this focal enlargement of an area. We could see a nodule that has these little discrete lobulations. They're typically going to be any echogenicity, really. They can be hyperechoic, hypo, isoechoic. Those are really fun to find when they blend right in. And they're also going to be vascular because it's just this enlargement of this focal region of thyroid tissue. So they're still tissue. They're not cysts, right? They're still a solid finding. They're just not anything for us to be concerned about if they're following the normal criteria. We also can have cystic nodules. So this is going to be related to the degeneration of an adenoma. We're going to hear the word adenoma quite a bit throughout this semester, and it basically just means the proliferation of any type of organ's tissue. So you can have adenomas of any organ. Any organ that has its own functional tissue can create an adenoma. So it's kind of like the blanket term that we give for kind of benign tumors that just pop up in any organ. Now, as those tumors get old or they start to die off, they are going to be replaced oftentimes by fluid as they're dying off. So that's when we get these cystic nodules. So it was once a solid tumor, now it's dying or degenerating, and it's becoming filled with cystic or serous fluid. We're going to see those degenerative changes. We can see some mixed components with this. So we could see some of that leftover solid component from when it was an adenoma, but we're mainly going to be seeing that cystic fluid. So we want to treat cystic nodules the same way that we do with the TRADS categories with regular nodules. So these, we would be aware of all of those criteria as well. Next, we have a follicular neoplasm. Now, I said we were starting off with benign findings, and this is technically benign, but it can be precancerous or it can be pre-malignant. So if we are seeing this, we don't want to ignore it. We don't want to follow it. We want to do an FNA, get some cells shaken out of it, and just get a definite diagnosis. If it does come back follicular neoplasm, even if it's, not in the malignant phases yet, chances are we still want to get that removed. It's the proliferation of those functional follicular cells. On ultrasound, it's going to be hypoechoic or isoechoic. We could see a thin hypoechoic halo surrounding it, which this picture is a really great representation of that. We're also going to see peripheral color Doppler vascularity. So we're going to be seeing vessels traveling around the outside or the periphery of the finding. And then we could see central cystic areas of degeneration. So we have our hypoechoic halo traveling right around it, and that kind of helps us to visualize it when we have those borders and those halos. We also can see those peripheral vessels lighting up because we have our color on. Next, we have a thyroglossal duct cyst. These are really cool if you have the opportunity to scan them. These usually are coming in from a patient who can feel this. They're very superficial in a very palpable area. These are congenital anomalies. So these are something that, you know, we're kind of just born with. It's going to be located midline of our neck and anterior to our trachea. So again, you can see that it's going to be very, very palpable. Now, if you were in my lab session, one of the last labs for the fall semester, I don't remember if it was my first session or my second session, I showed you guys how to use a standoff pad for something very superficial, and I put a huge blob of jelly right on my hand, and you could see how when I scanned that blob of jelly, I didn't push all the way down to my skin. I just lightly held the transducer on top of that blob of jelly, and it gave us this barrier, right? So that really helps us to evaluate what we call the near zone of our image. And we're going to learn that in physics, but that's what we're doing in this picture here. So this is all skin. Now, if we were to put the transducer right down on the skin without a jelly blob or a standoff pad, we wouldn't be able to evaluate it as well because it's too close to the transducer. So we need a little bit of distance for our sound wave to give us good detail in images. So we're using some type of standoff pad here, our trachea right here. We have our isthmus right here. And then we have this thyroglossal duct cyst right here. So very midline, very anterior. It can become infected, and that can cause pain and discomfort for the patients. On ultrasound, they are going to be cystic. They could have some internal echoes in them if they are becoming hemorrhagic or infected. When a cyst becomes hemorrhagic, that just means that it is starting to bleed into itself. So whatever vascularity is supplying that finding starts to bleed into it. That's when it becomes a hemorrhagic finding. Next, we have a branchial cleft cyst. So this is not like the brachial artery of the arms. This is a branchial cleft cyst. This is also kind of similar to the thyroglossal duct cyst in the sense that it's kind of like a congenital finding. And basically, when we are developing in utero, we have these very primitive cellular structures, and it's basically a remnant of that embryonic development in our neck. So those very primitive initial structures that we have that usually start to develop into more complex, sophisticated, complicated structures. For some reason in these patients, it just never, these primitive structures just never dissipate. And that's fine and normal, but we just need to know what this is if we happen to see it. So we find these lateral to the thyroid, so kind of in the neck tissue. And if we look at this picture here on the right side, we can see our carotid and our jugular here, right? So we're super lateral to that. And here is our cyst. So that whole thing is going to be that branchial cleft cyst. These are mainly going to be cystic. We can see some solid components to it, but usually not. And it could potentially be hypoechoic. So if it's cystic, we do want to see it anechoic. Usually they're pretty large. So the larger the cyst, the more likely it is to have debris in it, to make it look like there's echoes in it if there is debris. And of course, if there's any solid component, we would expect it to be hypoechoic. Next, we have a cystic hygroma. We actually learned all about this in our OB class, so this will definitely be coming back in the future. It's a type of congenital lymphatic malformation, and basically when the lymph channels in our neck, so the vessels that are responsible for draining all of our lymph nodes and our lymph fluid out of our body, they normally will drain into our venous system, but for some reason, if they don't have that connection between the lymphatic system and the venous system, or it's an abnormal connection between the two, that's when we get the cystic hygroma. We're typically going to see these on the back sides of our neck, the posterior lateral aspect of our neck. Clinically, we could see a webbed neck in these patients where it kind of just looks like it goes from like ears to shoulders on the patient. And then usually we're going to see a palpable, soft, kind of squishy mass in that posterior lateral region. On ultrasound, this cyst is going to be thin-walled, and it's usually going to be multiloculated. So when we're talking about a loculated finding, we're talking about like internal pockets. When you have a loculation, it's like a little separate cove or a little cave in a larger finding. So this is like the 5th time I've dropped this microphone. I apologize. So when we look at this ultrasound picture on the right side, we see all of these little different loculations. So we wouldn't measure each one of those, right? Because the whole finding is this. Those little pockets on the insides are just multiloculations or loculations. Moving into our malignant pathology. So now we're talking about cancerous findings. So our first one is going to be papillary carcinoma. This is the most common type of thyroid cancer, and the good news is it's going to have the best prognosis out of all of the thyroid cancers. It is a major route of metastatic spread. Just because of its proximity to the lymph node channels or to the lymph channels. Any type of thyroid cancer, whether it's a quote unquote better thyroid cancer, still has a high incidence of metastatic spread elsewhere because the thyroid is so closely related to our lymph channels. So that's a very easy way for cancerous cells to spread to different regions of the body by traveling through those lymph channels. Clinically, the patient's going to be asymptomatic. They are going to have potentially a painless lump depending on how big this cancer is. So if this is like the early stages of this cancer, you're never even going to know that you have it, right? Because you're asymptomatic and you probably don't even have a lump yet because it's still so small. So we're usually finding these when they're a little bit larger and a little bit more concerning. On ultrasound, they're going to be extremely hypoechoic. They're going to be solid in appearance with irregular margins. They're going to be lobulated. They're going to be taller than wide. And when we say that, that is a bad finding for anything anywhere in the body. When we say taller than wide, we are talking about a finding that invades the layers of tissue. So here, if we have, all right, so I'll draw it on our next slide because I have a little bit of room on that next picture. We're also going to see calcifications within the finding itself, which this picture is really good at showing those microcalcs. We don't ever really want to see those little hyperechoic punctate foci. And then we could see abnormal lymph nodes nearby, and that could signal that there is metastatic spread to those lymph nodes. So on our next slide here, I just want to, before we get into these pictures, I just want to kind of show you what taller than wide means. So here we have our picture, right? And we have all of our layers of tissue, right? Anterior, posterior, regardless of our transducer orientation. When we have a finding that looks like this, that is going to be taller than wide. So when you do an AP measurement of that or a height measurement, it's going to be, let me get a different color. This measurement is going to be much bigger than the width measurement. And that signifies a cancerous finding. When it's taller than wide, it's invading the surrounding structures above it and below it. When a finding is wider than tall, that means it's staying in its own plane. So when we see something like this, and we do an AP measurement of it, the AP measurement right here, the height, is going to be less than the width. And that is because that finding is not invasive. It's not spreading through the tissues above it and below it. It's staying in its own tissue plane. So that's going to be something that we see across the board from here on out in terms of documenting pathology. Now let's look at these pictures of papillary carcinoma. We have the pictures on top are really great because they're very tricky. It's very abnormal. It's a little bit more discrete than the pictures on the bottom. Pictures on the bottom, pretty self-explanatory, right? Hypoechoic, they're a little bit irregular. We have those calcifications on the inside. We're getting a little bit of shadowing, posterior shadowing on those bottom pictures. But if we look at the pictures on top, look at the borders of this thing. Super pointy, right? It's very angular, very ill-defined. Even this border on the next picture, you're like, okay, wait a minute. Where does it end over here, right? And wait a minute, does it go all the way out there? Like what is that? So that's what we call an ill-defined border. When we can't necessarily give a 100% accurate depiction of where that border of the cancer starts and stops. And that is notorious of cancers. Any benign finding, it's going to make itself known to you a little bit better than these ill-defined borders do. Next, we have follicular carcinoma. So this is going to be more aggressive than that papillary. It's going to be the second most common type of thyroid cancer. It spreads through the bloodstream, and it metastasizes very easily to our bones, our brain, lungs, and liver. So strangely enough, it's not going to spread metastatically by the nearby lymph nodes like we expect other cancers to do. It's going to spread through the bloodstream. So that venous drainage coming out of our thyroid, right? It's going to go all to wherever else it's going to go because of that venous drainage out of the thyroid, mixing with all the other blood and being transported elsewhere into the body. Clinically, we're going to see this in older female patients on ultrasound. It's going to be indistinguishable from an adenoma. As we said, adenomas are that tumor made up of any functional tissue of any organ. So we need to do an FNA, a fine needle aspiration, to get some cells out of it to send it for testing. They're typically going to be hypoechoic. We're not going to see any halo. We're not really going to see any cystic spaces within it. So these are going to be a little bit more easy to confuse with something benign, right? We don't see irregular margins. We don't see super hypoechoic finding like papillary. We don't see microcalcifications in there. We don't see any lobulations of the borders. So it kind of looks like it behaves a little bit, right? And that's why it's hard to distinguish it from just a regular benign tissue tumor or adenoma. So we need to sample that and we need to make sure that we get a diagnosis. Next, we have medullary carcinoma. So this is going to be the less common type of thyroid cancer, and it accounts for only 10% of all thyroid cancers. So we're not really seeing these too often. It's going to originate from the parafollicular cells, and they secrete that calcitonin. So we're going to be seeing these calcifications within these findings. Clinically, they are going to be hard and palpable, and that's because they're very calcium dense, these findings. So they're going to be very hard. Cancers typically are hard. Malignancies typically are dense and firm. Anything soft, squishy, mobile, that's going to be more towards the benign category of a finding. Anything firm, hard, fixed in place is going to be more malignant. We also are going to see abnormal blood serum calcitonin levels. On ultrasound, it can appear similar to that papillary carcinoma, but they're mainly going to be much larger than that. And we could potentially see some cystic changes where we don't normally see that with papillary carcinoma. They could be homogeneous, and we are going to see those calcifications. So here we have our whole thyroid border. And then here we have the entire medullary carcinoma. So this is occupying like the entire thyroid gland itself. So they get very big. Next, we have anaplastic carcinoma. So this is going to be a rare, very rare type of thyroid cancer. This accounts for less than 10% of all thyroid cancers. It's going to be the most deadly form of a thyroid cancer as well. We see this in patients over 50, clinically hard fixed mass. They have rapid growth. So these things are growing basically like overnight, and a lot of patients will have death by asphyxiation because they get so large. they basically just choke. And it's absolutely frightening. A patient will have pain, pressure, tenderness, going to be locally invasive. So it's going to affect all of that thyroid tissue, the surrounding structures, musculature, all of that, all of those other supportive structures. On ultrasound, they're going to be very large, hypoechoic, heterogeneous. We could see calcifications. We're going to see it supervascular. We're going to see invasion into those vascular vessels. So we can see the tumor actually spreading into the carotid and into the jugular. We're also going to see it spreading into the lymph nodes, into the surrounding soft tissues of the neck. So these are very, very, very aggressive and very unfortunate. Also very variable in appearance, like a lot of malignancies are. And next we have lymphoma. So rounding out our thyroid malignancies, when we see lymphoma in the thyroid, it's primarily going to be non-Hodgkin's lymphoma. Now, does anyone truly know the difference between Hodgkin's and non-Hodgkin's lymphoma? I particularly don't, but for me and for the registry, you need to know that if you're seeing lymphoma in the neck, if you're seeing lymphoma in the thyroid, it's going to be non-Hodgkin's. It's going to occur in older females, so we just get all the fun stuff. We just, it's great. We have breast cancer, thyroid cancer, lucky us. It's going to account for 4% of all thyroid cancers. So again, very rare to see lymphoma in the thyroid. Lymphoma is going to be something that affects the lymphatics of kind of our entire body, but it can spread into organ tissue. So this is what we're talking about, if it spreads into the thyroid tissue. Clinically, we're going to see rapid growth of a neck mass. If you have pre-existing Hashimoto's, you are more likely going to get lymphoma than somebody who does not. So more than 90% of cases of lymphoma in the thyroid have an association with pre-existing Hashimoto's. So again, we need to keep track of our clinical history, our lab values. We need to get an accurate diagnosis in order to make sure that we are aware of what to be looking for in the future, and in terms of what our medical future will look like as a patient. On ultrasound, we are going to see hypoechoic heterogeneous mass. We could see some echogenic internal septations, kind of similar to loculations, but septations really divide it right in half. Loculations are kind of like the little internal coves, and it's going to have a similar appearance to Hashimoto's, the thyroid itself, not the lymphoma within the thyroid. So here we have our massive lymphoma within our thyroid. Our thyroid is all of this tissue. We're cutting it off, cutting it off, cutting it off. And this is our lymphoma. So again, very, very prominent. And finishing up with our parathyroid pathology. So as we said on our previous PowerPoint, we're not seeing the parathyroid glands unless there is something wrong. Now, what could those something wrongs be? We could have, similar to the thyroid, we could have hyperparathyroidism, and we can have hypoparathyroidism. Now, hyperparathyroidism is going to be a little bit more concerning. We're not really going to talk about hypoparathyroidism too much, just the underfunction of those parathyroid glands, but that doesn't really cause us like too many issues. When we have hyperparathyroidism, we actually break that up into two categories. We have primary and secondary. Primary is going to be when we have the increased function of those parathyroid glands, and that is going to result in those increased amounts of that PTH, potentially caused by an adenoma, a cancer, or any other type of abnormal proliferation of tissue. Now, when we have those increased amounts of PTH, we're going to have the increased function of the parathyroid, right? So it's going to be functioning more than it should. It's going to be producing more than it should. It's going to be 3 times more common in women, especially after menopause. Clinically, we're going to see patients with hypercalcemia and hypercalciuria. So what does this mean? This means we see too much calcium in our blood and too much calcium in our urine. On ultrasound, we are going to see enlarged hypoechoic parathyroid glands right in that posterior aspect of the thyroid, depending on if it's the superior or the inferior parathyroid glands. And next we have secondary hyperparathyroidism. So this only will occur in patients who have chronic renal disease or chronic renal failure. So their kidneys are shutting down and we have the inability to synthesize our vitamin D, and it's going to depress the serum calcium levels. So basically, our kidneys are failing. Therefore, they can't process vitamin D. Therefore, that vitamin D lower level, that lower level of vitamin D is going to result in those lower levels of calcium. And this is kind of why I said previously that our parathyroid is going to, and our pituitary gland is all very closely related to our kidneys, as odd as that seems. But this is why we have this very delicate, kind of unspoken relationship between our kidneys and our endocrine glands. Now, it can affect all 4 of the parathyroid glands, and on ultrasound, same thing in large hypoechoic glands. So if we happen to do see parathyroid glands, we are not responsible for determining if the patient has primary or secondary hyperparathyroidism. Like that's not the reality of going to clinical. In terms of the registry, you need to know the similarities and the differences, but as a technologist, it's your responsibility to accurately document those parathyroid glands and to know that it's abnormal for you to be seeing them. So doctors love if you can give them what we call a differential diagnosis, meaning it can be this or this. Right? So when you see those malignancies, those thyroid cancers, and you see them with the calcifications, right? You could say, all right, they're both hyperechoic, they both have calcifications, they're both irregular borders. It could be papillary carcinoma, right? Or could be medullary carcinoma, right? Look at how similar that looks to this. Now this one's much smaller, but they look kind of the same, right? You wouldn't say, oh, it could be medullary carcinoma or lymphoma, right? They don't really look the same. So we want to be intelligent and we want to be eloquent in the way that we present cases to a radiologist or to a physician. We want to show them our education. We want to show them that we know what we're talking about, we know what we're looking for, and we know what falls into certain categories. So the thyroid is going to be very tricky when you guys first start scanning. Oh, let me just finish off one last slide here. Our parathyroid, sorry, 2 more slides. Parathyroid adenoma. This is going to be the most common cause of primary hyperparathyroidism. So a parathyroid adenoma is the proliferation of that parathyroid functional tissue. So it's just a tumor made up of that parathyroid tissue. Now, if we have a tumor on the parathyroid, that is going to result in primary hyperparathyroidism, as we just said a few moments ago. So on ultrasound, this adenoma in the parathyroid gland is going to be small. It's going to be round, solid, hypoechoic, and hypervascular. So that is going to be this guy here. Not to be confused with the vessel. We have our carotid here, jugular here, posterior to our thyroid is our parathyroid, and that is going to be our adenoma. Here is our thyroid tissue and trans. And finishing off here with our parathyroid carcinoma, so a very small percentage of patients with primary hyperparathyroidism can have parathyroid carcinoma. Again, this is going to mainly be shown by blood work and other imaging. So we're not solely relying on ultrasound for these differential diagnoses and answers. So not to stress you out a little bit. This is a malignant neoplasm. This is a cancerous condition. It's hard to differentiate between this and just a regular parathyroid adenoma. Surgical excision is going to be the only way that we can definitely 100% diagnose it. We're usually not biopsying or doing an FNA of the parathyroid because of the location of it. They're very posterior. They're surrounded by very sensitive structures, right? We have our carotid right there. We have our jugular right there. So there's not really a safe way to approach how to biopsy or how to get a needle into that parathyroid gland. And usually, as we've said, if we're seeing a parathyroid, it's because there's something abnormal. So we might as well just surgically remove it anyway and then figure out what it is. On ultrasound, these are going to appear as a large irregular mass with slightly lobulated contour. So as I was saying, thyroids are going to be very tricky for you guys to be able to find pathology, but they are a great way for you to practice finding pathology and measuring and documenting that pathology. You're going to find your first nodule, you're going to measure it, you are going to feel so accomplished, and then the tech is going to come in and measure it completely different because you actually missed a border. And that is just going to happen, and that's something that you are going to learn from. Once your eye sees that true border that the tech shows you, you're going to see that from that moment moving forward. So you just need to see these things. You need to do them. You need to practice them. You need to bounce the knob off of your techs and take what they're showing you and take what they're trying to visualize in the picture to help you for future exams. So any questions about this module, please feel free to reach out to me. Tons of new information, but it all kind of works hand in hand with each other. Anything, please reach out, and we are going to start practicing thyroids as soon as we get back into lab.